Well, thank you so much for this opportunity to share some of our ideas and data with you. And sort of, I start with this Renoir very often to suggest to you that really what we are interested in as clinicians are patients such as these who have sort of reduced quality of life. You can see this lady is lying down because she needs peritoneal dialysis to deal with the consequences of her obesity and diabetes. And really what I want to do is not make this lady thin, but what I want to do is turn us into those patients in the background here who have a better quality of life and an active lifestyle. So what I want to do is I want to go beyond just making people thin. I want to actually see how we can make people healthier. And so this idea of pharmacological adjuncts to bariatric surgery is really an idea that was born out of our clinical practice, where in our practice we actually have diet and exercise, we have pharmacotherapy, and we have bariatric surgery. And I'm in a fortunate position that I'm a little bit agnostic as to which treatment is best for patients. What I want to try and do is get the best treatment to the right patient at the right time. And sometimes that is surgery, sometimes it's medication, sometimes it is diet and exercise. However, I'm not as clever as most of my colleagues, because many of my colleagues say that they can walk into a room, put their hands on a patient and say, you will do well with medication, or you will do well with drugs or surgery, etc. I'm just not that good. So what we had to do is to actually try and work out strategies of how we can actually do things together. Those are my conflicts of interest, and really I sort of put up a bariatric surgery operation there because everything I know about surgery actually happened, about obesity rather, happened because I had the fortune of interacting with patients who've had surgery in a very early stage as part of my PhD, and Katie Winner's in the audience here, and we did our PhDs together. And I was really actually listening to patients after they've had surgery. That opened my eyes to how much people suffer when they're obese, how much benefits they have after the operations, but also how hard it was for them to get to the decision to actually have surgery, and that whole journey and how we can actually optimize it. So these operations are incredibly good. And it's a failure of mine, and that we have not been able to increase the penetrance of these treatments. How is it that we have treatments that is so good? And I can show you the SOS study that we all know very well. A treatment that can actually maintain 25% weight loss or 15% weight loss, and yet we only treat less than 1% of the population that can actually do this. Why is it that we haven't been able to do better in getting more people to have these treatments? And that sort of drove us to actually think about how can we do things a little bit better, and especially how can we do it together? Because no doubt the weight loss, and as I always say to people, that's not difficult. I can make anybody lose a third of their body weight. I lock them in a room, I give them 2 liters of milk a day, 3 months later they come out, they've lost a third of their body weight. But at that point, when they come out of those rooms, they are like starving Marvin. They're incredibly hungry. So, but the benefits of surgery is not the weight loss. The benefits of surgery and the magic of surgery, I would suggest to you, is the weight loss maintenance. But again, I remember looking at these graphs at a very early stage of my PhD, and what struck me is that this means if surgery can do this, it means it's physiologically possible. We can actually make people lose weight and maintain their weight loss. We just haven't worked out how to do it yet. And I joke very often with many of my surgical colleagues who's in the room, and I say, you guys found the answer without understanding the questions. So we have to sort of back engineer it now a little bit to actually try and work out why it is that surgery is so good. Because the other thing that I hear and you hear, when you talk to your patients after they've had profound weight loss, and this is the data from Phil Schauer in the Stampede study, looking at the blue with the best medical care, the green sleeve, and the orange gastric bypass. And what it shows is that people actually have a better quality of life. And on each of the domains, surgery outperforms best medical care. So how is it that we don't have this? And of course, when we actually look at surgery now, I'm thinking about surgery in my clinical practice not as an acute intervention. It is or not as an acute treatment, rather. It is an acute intervention, I should say. The surgeons take the patient to theatre. It's a 45-minute skin-to-skin job. Patient leaves 1 day or 2 days after they've come into hospital. That's an acute intervention. But what the surgeons have given me is the perfect chronic treatment. Because every time that patient has a meal, that patient has a phenomenal gut hormone response. Every time that patient has a meal, that patient has a bile acid response. Every time that patient has a meal, they maintain the gut microbiota in a perfect balance to actually drive the metabolomic signal. So I am now thinking about bariatric surgery as a chronic treatment that I have. And again, it was John Dixon in the audience that sort of, started this discussion. He was the first one that I heard that made this comment that really we need a chronic care model for obesity because it is a chronic disease. And it turns out that surgery is just one of the best chronic care, treatments we have, for this. Because why? What happens with surgery? This is Sahid Ikramudin's randomized controlled study. We see that, yes, of course, the weight loss, but it's not weight loss on its own, because here's the hemoglobin A1C changes. We actually see there's no change when it comes to lipids, but actually there is improvements when it comes to hypertension. But I want to focus just for a moment on the lipids over here. And the reason why there was no difference when it came to surgery versus medicine when it comes to lipids is because we are incredibly good at treating dyslipidemia. I remember working in lipid clinics, and as many of you may remember, back in the 1990s, or even early part of 2000, we actually had dietitians in lipid clinics. And the dietitians, patients would come in with familial hypercholesterolemia, and we would give them diet advice. It was utterly useless. And we couldn't shift LDL cholesterol with those. And then we actually have statins. And we had LDL apheresis at the Hammersmith because we were looking after patients with severe familial hypercholesterolemia. And now we have newer medications. So our treatments are now so much better that we effectively don't have dietitians in lipid clinics anymore. We just have really good treatments. And it shows you that if we have good pharmacological treatments, that weight loss on its own doesn't actually add benefit. But what it also hides is that the patients after gastric bypass over here needed much lower doses of the drugs. And you will know as well as I do that the poison is in the dose. And when we actually treat patients with statins, for example, our initial treatment is where we get most of our benefit. And when we double a statin, we actually double the side effects very often, but we only get a 6% additional reduction on our LDL changes. So really what I want to do is I want to be able to treat people with the lowest doses of the medication that is effective to actually get to my targets. And that again helped us to actually get to where we wanted to be in this thinking. So here we have, of course, you've seen me say this many times, this is why it is such utter hell to work in an obesity clinic if you have just a general non-surgical treatments, because you have this clinic, people come, you try to give them a new diet, they come back, it hasn't worked very well, you give them a little pill, it doesn't work terribly well, they come back, and then at some point the patients stop coming, and as I said yesterday as well, at that point we as clinicians blame the patient, so we say, they're just not very motivated. In fact, it has to do with our treatments that is generally so rubbish. However, if you work in a service where you actually have surgery as part of that paradigm, then suddenly what you also see is you can actually shift, because instead of just focusing on morbid obesity, now you can turn those two words around, and now you can focus on obese morbidity. Because suddenly now you can actually make people healthier. And we can actually look at what are the health domains that we can improve, and this is Arya Sharma's work. We can talk about medical improvements, mental improvements, and functional improvements. And here we have, the stages 0, 1, 2, 3, and 4. And that allows us to move beyond weight. Now, what this allowed me to do, and I'm sort of sharing a little bit of my journey for whatever it's worth, But when I sort of saw this for the first time, what it allowed me to do, as a senior house officer, I did a cancer job, I did an oncology job. And I remember, the oncologist, they operated on, tumor node metastases. And very often we had a patient that was a T3 cancer, so, maybe a T3, so really big cancer, but it was an N0, M0. And sometimes we had patients that had a T1 cancer, but it was N2, M2, right? So the size of the cancer didn't determine the malignancy. The malignancy was determined by other factors, but we could measure the malignancy by just staging the patient. And, this was the same, thinking when it comes to obesity. The size of the patient does not tell you how malignant the obesity is. The malignancy of the obesity can be staged, and we know when we actually stage this is again, Arya Sharma's work, we can see that people that are really big as houses, but have nothing wrong with them, so stage 0 on the Edmonton scale, if they come into your office, you can give them a follow-up appointment for 20 years, because those patients are going to come back after 20 years, it's 200 months, and they're effectively not going to die. But if a patient comes into you that's much less heavy, but they actually have prediabetes or diabetes with cardiovascular disease, you can actually tell the malignancy, and this is the mortality that's going to happen over time, by what else is going on in the patient. So of course, we can actually look at how much weight do you have to lose to become healthier, and that depends a little bit on what's wrong with you. So, and that led us to develop the King's Obesity Staging Score, where we could use this in clinic, and so I can remember it in clinic. It goes alphabetical, so from A for airway, B for body mass index, cardiovascular, diabetes, economic, functional, gonadal, and health status perceived, which is quality of life and image. And then we can stage it at stage 0, 1, 2, and 3. And really what I want to do with my treatment, irrespective if it's diet, exercise, medication, or surgery, in the same way as with cancer, I want to downstage the disease. I want to take people who is on CPAP and I want to downstage them maybe so they actually don't need CPAP anymore. Or I want to take people with uncontrolled type 2 diabetes, and we know that after many of the metabolic surgery procedures, we can downstage them into normoglycemia. So then that really helped us, because now, when a patient came into clinic, I was able to stage them like this and actually say, I don't know how much weight you're going to lose, but what I can say is this is what I want to achieve. And when you come back into clinic next time, I'm actually not going to weigh you even anymore. And that was a really sort of a bit of a radical, thing to do in clinic, because we were talking to our, registrars in clinic, and we were saying, listen, it's not about weight loss. And they said, but look, what happens, the patient walks into the clinic, the first thing that happens is the nurse frog marches them and puts them on the scale, and the first thing the patient wants to do is to know how much, weight have I lost, and then the patient walks in, and, we worked in the NHS, so, everybody knows the game, and everybody knows how to do the dance, and the patients are, no, we're here for our health doctor, and we are saying, no, we are really here, to make you healthier, but how much weight have you lost, So we actually said, all right, let's put our money where our mouths are, and let's stop weighing patients in an obesity clinic. And that freaked out the nurses, as you can imagine. But it allowed us actually to say, okay, so I'm not interested. And what I did, Katie may actually remember this, my clinic was on floor number 5 at Charing Cross Hospital. So we actually got the estates to number the little steps between floor number 5 and floor number 7 on the stairs. And so instead of the nurse frog marching patients onto the scale, they frog marched them onto the steps and then said, okay, walk up. And then every step had a little number, and then the patient would walk up, and where they stopped for the first time, that was a number that was written down in the medical notes. And then when they came back 1 year later, we could actually walk them up again, and we can actually see, did we make a difference? So that was on the functional improvement over here, because that was actually a hard number that meant something. So now we actually made people either lose weight or we made them healthier, and now they could actually climb more stairs, etc. So that just but what the staging score also allowed me to do, thinking back about my oncology job, is yes, we very often use our initial treatments, in cancer to downstage the disease, and typically surgery is what we go to first. If somebody has breast cancer, we downstage the disease, but then the hard work starts, because once we have downstage them, that's just half of the job done, or maybe a quarter of the job done, because then what I want to do is I want to maintain that patient in remission. And that's why, the STENO2 study that shaped our thinking so much, because this, again, is a randomized controlled study done in Denmark in an incredibly good way. Small numbers, 80 patients in each arm, but what they did is just looked at conventional therapy. Now, this is in the Steno Center. I'm not sure if you guys have visited. I've had the fortune of visiting. This is like the best place for diabetes in the world. So they actually had conventional treatment in the Steno Center, but actually then they were able to intensify their treatment by just using the medications that we had in an optimal way, and showed that we can actually, in a randomized controlled setting in patients with diabetes, show a mortality benefit if we just treat people to target. And that's not rocket science, but here we have hard evidence. Now, why are these targets so important? Because here we have both the reversal and the asteroid study, and this is using intravascular ultrasound. You guys may be familiar with this, pretty old techniques. That's a little intravascular ultrasound probe in the coronary artery over here. And what you can see, that's what the lumen should look like of the coronary artery. In fact, that's all that's left of the lumen, because all of this yellow bit over here is plaque. But in biology, anything that moves in that direction can actually move in that direction if you change the metabolic milieu. And again, there was an old boss of mine who said, he trained as a pathologist, and in those days they still had to do autopsies. And he said, it was the weirdest thing, because if we had an 80-year-old gentleman that came in that died of, natural causes, or and we actually looked at their coronary arteries. The coronary arteries were generally packed. If you're 80 years old, you had lots of time to build up plaque. But if we had an 80-year-old that came in with cancer, and we actually cut through the coronary arteries were completely clean. Okay? So what that suggests is that the body can actually change. Even atherosclerosis that when I trained at medical school, people thought this is a one-way traffic. You could just build more plaque, and all we can do is just slow it down. But what this study has shown is that if you treat people with high doses of statins, and the only reason we treated them with high doses of statins because that's the only way to get their cholesterol down to an LDL cholesterol of about 2 millimoles per liter, then what you can do, that's the plaque of the patient pre, and that's the plaque of the patient post. So you can shrink down atherosclerotic plaques if you actually treat people to target. So, that sort of goes on to now some of the newer medications that we have. So here what I'm showing you is the leader study with liraglutide, where in patients with type 2 diabetes, liraglutide has clearly shown to have a mortality benefit above placebo. Now, why this is important is because liraglutide doesn't only do one thing. It doesn't only reduce glucose. It also reduces blood pressure. It also reduces inflammation. It also reduces body weight. Does that make you think about something else? Right? So that sounds very similar to bariatric surgery that does all these multiple things. So you can't only do one thing and expect a benefit. You actually have to do multiple things. But what this shows is that it is possible to actually drive a mortality benefit. So whenever any of you sit and somebody stands up and says, surgery is rubbish, it's risky. We all know that it's not risky. We all know that the risk of surgery, is similar to a hip replacement or a cholecystectomy. So it's just not true. But on the other side, the same is true. Medical treatment is also not rubbish. I've listened many times as saying, oh, everybody should just go to have one treatment like surgery because, medical treatment is rubbish. Medical treatment isn't rubbish because, look, you have a mortality benefit here in a randomized controlled setting. And we've never been able to show that with surgery because the actual numbers needed to treat is so high. And the reason, just to make the point here, look at the placebo arm and then look at the overall mortality in these high-risk patients over 54 months. We today, you, especially many of you who are general practitioners, have really moved the needle in reducing overall cardiovascular events because you actually have good treatments today. You have metformin, ACE inhibitors, and statins. And once you give those to patients, nobody dies anymore, really. It's amazing how much difference that has made by just using good, simple treatments. And if we actually add liraglutide to those good, simple treatments, we can actually have an additional benefit. Just to drive that point home, we can also see the same is true for empagliflozin, another class of drug that has, this has revolutionized the way we actually think about diabetes because now we have two classes of drugs that reduce glucose but also make people live longer. A completely different mechanism, but just look at that benefit. But we should not forget the old data when it comes to, this is the UK PDS study, showing metformin over a 25-year period also having a mortality benefit above conventional treatment. And that's really, I suppose, where the next bit of the talk kicks in because, the talk is, what's the idea about adding medication to surgery? So the first thing I would ask you to consider before we go to the radical step of adding medication to an already very good treatment such as surgery is, can you at least consider the idea about what is the benefit of stopping a medication that has a mortality benefit when we are treating people with surgery? Right? Because so many of my colleagues, when we actually treat people with very difficult to control diabetes, and we just had the World Obesity Day media launch in Ireland yesterday, and that was what we went to the media with, is this, old, it's what Walter Pori, wrote about, who could have thought that, surgery turns out to be the best treatment for diabetes, because you really just have to see one patient, N equals 1, of a patient coming in on 100 units of insulin on a Tuesday, having an operation such as a gastric bypass or sleeve gastrectomy, and the patient leaving the hospital on a Thursday with perfectly controlled perfectly controlled glucoses, not needing any insulin. You really have to see one of those patients to actually change your mind. And when you've seen a series of them and you understand that this is a very predictable event, then you actually think, wow, this is amazing what surgery can do. But it's been so amazing that, and I was guilty of that myself, we wanted to wear this badge of honor to suggest that we can cure people, with surgery. And the only way for me to prove, to my colleagues that I could cure them is to rip all the medication out. So I would stop the metformin, stop the insulin, stop the ACE inhibitors, because then I could show you just look at how powerful surgery is. And that was perfectly reasonable to do in the early part of 2000. But now, I'm posing the question, why would I stop a medication such as metformin? Or here is the advanced study with ACE inhibitors, again showing a mortality benefit with perindopril above placebo. Why would I stop a drug that actually makes people live longer? That's different to actually, I don't want people to stand up and fall over because they're hypotensive. I don't want to cause, a hypoglycemia in everybody all the time. But remember what we said in the beginning, that the poison is in the dose, and if we can actually keep the medication but actually reduce the doses, we can have much of the benefit without having some of the side effects. And Francesco Rubino, who gave some excellent talks already at this meeting, he published, together with Galtwick Mangroni, the 5-year data of their randomized controlled study. And you'll remember they are randomized patients with medical treatment, or gastric bypass, or BPD, biliopancreatic diversion. And when they actually looked at the American Diabetes Association criteria for complete remission, right? Complete remission what they showed is in the medical arm, 0 people achieved remission. In the bypass, 0 people achieved remission at 5 years. And even after BPD, 0 people achieved remission. And we wrote the editorial and we said, Mangroni and colleagues' study lay the foundation to start the hard work of maintaining diabetes remission once surgery has leveled the playing field. And that brings us back to the cancer care model, which I would suggest is something that we can learn a huge amount from. So we can learn how cancer care has improved by having tumor boards, by their multidisciplinary clinics. And, you know, and we in obesity we have embraced the idea of interdisciplinary working and multidisciplinary working. But cancer care has also allowed us to move away from just putting people in remission, but actually putting the focus on maintaining remission. Right? And, you know, I have not met many oncologists or cancer surgeons these days that stand up at meetings and have arguments about my operation is better than your chemotherapy or radiotherapy agents. What I hear and what I see with all the cancer trials is I see the cancer trials actually looking at, you know, what is the best way to actually enhance the surgery. Do we use chemo and radiotherapy pre-surgery, or do we use it immediately after surgery? What are the right doses? And how can we effectively put our cancer surgery on turbocharge? How can we make our cancer surgery even better than it is at the moment? And yes, there's huge advances in the surgery itself from a technical point of view, but also other approaches. But the real thing that's moved the needle is to actually say, how can we take cancer surgery and make it better? And I would suggest to you that we can actually start thinking in obesity in the same way. Again, as an internal medicine doctor, I would like to see more operations being used. But the only way I think we're going to do that is to actually make the operations that we have, that's already very safe. We can fiddle around on the safety aspects, and we can make it even safer than it is, but we are really sort of, you know, faffing at the margins because it's already so good. But I think we can actually make the surgery far more effective than we have it already by actually embracing the cancer idea of actually using pharmacotherapy to actually add to it. And it was Phil Schauer again that was the first one to actually drive that idea in his Stampede study. And I'll show you here the 5-year data, you know, of the medical treatment. And here we have glycemic control, the hemoglobin A1C, sleeve gastrectomy and gastric bypass. And what you can see, the sleeve gastrectomy and gastric bypass, you know, end up at exactly the same point when it comes to glycemic control. Now, again, you need to read the paper, and you will know that the patients with sleeve gastrectomy actually required far more pharmacotherapy than the patients with gastric bypass. But that is the point. The point is, you can make any operation as good as another operation by adding a little bit of medication, because the amount of medication that had to be added to the sleeve gastrectomy was really minuscule in comparison to the amount of medication that we have to use to treat these really difficult patients with diabetes had they not had surgery. Remember, these were our nightmares in the diabetes clinic. These people came in with hemoglobin A1Cs of 9.5 despite best medical treatment. And yet what they were able to do is take the really hard patients, you know, drop their hemoglobin A1C by almost 3% and maintain it over 5 years. And all you had to do is use the best treatments you had, which is surgery, and then put your surgical treatments on additional turbochargers, I said. So John Dixon and myself and others were involved with the International Diabetes Federation back in 2014, or actually earlier than that, 2011, I believe. And this was the criteria that came out at the time, what the International Diabetes Federation suggested we should use to actually think about what's called optimization of the metabolic state. So they talked about hemoglobin A1Cs less than 42, that is 6%, no hypoglycemia, total cholesterol is less than 4, LDL cholesterol is less than 2, triglycerides less than 2 and 2.2, blood pressure less than 135/85, more than 15% weight loss. And this is the important message, with reduced medication. right? Not with no medication, with reduced medication. And we know that this is what Steno-2 effectively tried to do, and they weren't able to achieve the 15% weight loss, but we know that the 15% weight loss, which is only possible at the moment with our surgical treatments, is really what drives down inflammation. And we know that inflammation is the thing that we cannot change without surgery. I don't have a drug that can change, that can drop my CRPs. In most of your patients, if you go and look at all your patients with type 2 diabetes and obesity, they're all running CRPs of 6s, 7s, and 8s. All right? And if we can, and if those patients have surgery, 3 months after they have surgery, they're running CRPs of 1s and 2s. Okay? So that reduction in inflammation appears only to be possible with this 15% weight loss. But if we do this together, like Steno-2 did, then I think we're going to see a lot more benefit. So here's my own results about how good we were. So we were like part of writing the criteria. We had a clinic that was focused on this, and we were utter rubbish at actually achieving this. So this is, how many patients in my clinic, had IDF optimization. God knows, it's only like 10%. And this is with surgery, because even if you think you're doing this, you're actually not doing it well enough. So this is hard stuff. It's very hard to achieve this, but that is why we need to work in a combination, especially with general practitioners, but also with everybody in the team understanding what it is we want to do. So I'm going to just quickly sort of make the point when it comes to also why we want to use pharmacotherapy with surgery, is you will see this type of graph in anybody that's done more than 1,000 operations. Doesn't matter what operation they've done. This is actually from Rachel Batterham's group at University College London. And you can see here we have bypasses and the amount of weight loss that people have. Here you have sleeve gastrectomies, and this is total weight loss that you have. And what you see is a perfect Gaussian distribution, right? And what that means is that surgery is a biological treatment. It does not work through restriction and malabsorption. It works through biology, because this is the evidence, right? But the patients that actually didn't lose any weight, even with the bypass over here, were not less motivated than the patients that ended up on this side. It's purely biology. And we see exactly the same when we treat people with lifestyle treatment, with medications, etc. And this is the look-ahead study, and you will be familiar that with look-ahead, we could also achieve some weight loss maintenance, but it made no difference to a cardiovascular outcome until they did the post hoc analysis that was published in the Lancet Diabetes and Endocrinology in 2016, and showed that patients that achieved 10% of their body weight had a primary outcome, 21% statistically significant reduction in cardiovascular death, non-fatal MI, stroke, and admission to hospital. And also a secondary outcome, 24% reduction in coronary artery bypass grafting, end arterectomy, heart failure, etc. So it turns out that what we're seeing is responders and non-responders. In the same way as with surgery, we see even with our surgical treatments, there are some people that are non-responders and there are some people that are responders. So we shouldn't blame our patients if they don't respond to our treatment, but what it allows us to do is to say that those patients are certainly the ones that actually needs the escalation of treatment. And we see the same when it comes to liraglutide. I've shown this graph again. I'm going to show it a couple of times in this meeting because I think it really makes the point. Here we have patients in the red line that was treated with diet, exercise, and liraglutide. Here in the yellow line, we have people on placebo. And you can see that 8% of patients with diet, exercise, and liraglutide over here gained weight while they're on this clinical trial. We see that 2/3 of people lost 5% of their weight, a third lost 10%, and 14% of patients lost 15% of their weight. When we look at these responders over here and we look at the non-responders over there, we could not tell them apart by looking at any of their psychological profiles or any of their biomarkers. So that's an important point also when it comes to treating patients, is don't think that you are clever enough to pick the patient that's going to respond to surgery. And the whole day in your surgery, you sit and wait for this magic patient to walk through your door that's going to announce themselves as super motivated and deserving of having an obesity treatment. Actually, I would suggest to you that we do not have the ability to do that. But what we have the ability is to actually treat people and then change our treatment or escalate it depending on our responses that we see. And now that the next time when you see a patient that comes through the door that have had weight regain after surgery, our initial thought is, oh my God, I should have known that this is not a motivated patient, or I should just see how, now they're eating again, they should really know better. But that's because we're not understanding the disease. So even when people don't respond to our treatments that is as powerful as surgery, don't think about blaming the patient because it's not right. But biologically, it's not right. Never mind morally. Biologically, it's not right. But actually then think about how can we optimize their outcome. Because even if we don't have as much weight loss, we can have a lot more metabolic benefit if we actually combine our treatments, in a pharmacotherapy plus surgery type of way. So I'm going to conclude and suggest that personalizing approaches remains challenging. And yes, it's the 21st century, and yes, we're a little bit into the 21st century already, but, we will get there. We will be able to predict pre-intervention, but we're not there yet, but it's challenging. So using existing drugs at optimal doses have most of the benefit. But combinations of medication with medical devices or surgery holds promise. So certainly this is aspirational at the moment, and we need to go out now and prove that it works. Okay. But I think, it is possible to do those studies, but at least at the moment, you need to start thinking about it's not surgery against medicine. And I'm going to conclude with that because we've seen that in the US where they have far more medical treatments. They have more drugs than we have in Europe or you guys have in Australia. But what the guys did in the pharmaceutical companies in the US, they did sort of this classical circular firing squad approach. So the one company was saying, those guys are rubbish, they have a lot of side effects, and the other company was saying, no, those guys are rubbish, they don't have much effect. And what they did is they shot each other, and then the regulators just stood back and said, clearly these guys, we don't have good treatments, we just have to wait a little bit longer until we have more consensus. So don't fall into that trap where we also have a circular firing squad with surgeons and physicians saying, no, surgery is unsafe, or no, medicine is rubbish. What we really need to do, and Ahmed showed that great slide yesterday about just our penetrance of treatment is pathetic. We have great treatments. We have better medications now. We have good lifestyle treatments. It doesn't work for everybody, but it works for a small number of people. But we need to get to those patients. So I would like us to see more treatment. I would like to see more surgery. I would like to see more pharmacological treatments. I would like to see more combinations that we have to just increase the penetrance of the treatments that we have. So and it's a little bit hard to do that. But at least if we know that we shouldn't blame our patients if they don't respond, that helps a great deal. Of course, just to thank the team at home actually doing all the hard work, especially Neil Doherty, who is my co-director, and then also acknowledging all our international collaborators. So thank you very much.
Look, as my hat as president, I've got to say Steve Smith is going to be giving his clinical keynote in about 5 minutes. So I think there's enough time to get from here to there. But as somebody who is vitally interested in what Carel said, if there's one question that stands out, I think we have time for a quick question, if there's one. Otherwise, we'll just adjourn. I thought there might be John. Hi.
So I work in a diabetes heart disease research centre, and we work up our patients for surgery very, very well. We refer them out. Do you know how many get referred back?
Yeah, no, and just the last to John's point, and I learned a lot from where John and their practice operated. But when we set up our practice, we were very small, so I was able to see everybody that came back after surgery, and that is what reinforced my understanding of surgery and the benefits of surgery. Because what I saw is I saw the 95% of people that had these incredible benefits, but I also saw the 5% of people that had problems. But I could see that imbalance. Some of my colleagues who are not as fortunate as I was, what they do as internal medicine doctors, they refer people, but they only see the problems coming back, which reinforces the idea of problems rather than of benefits. And that's, again, where our surgical colleagues can actually help themselves and help us by actually making sure that people see all the benefits of surgery, by making sure that the general practitioners as well as the internal medicine doctors that refer the patients see the benefits. And the only way we're going to do that is by a combination approach. So John, I think that's going to drive penetrance of our treatments, and I also think that by doing that, we as internal medicine doctors and general practitioners need to add benefit to surgery. It's not surgery and now we take our hands off, it's actually surgery and how can we make it work better. So thank you very much.
Okay.